let me give you a quick background of this. This actually we had to telecast or rebroadcast on a weekend, and this is our 2020 Basildon A to Z course. So unfortunately, when we looked at our recordings, this one was faulty. So I decided to do it live. And please remember, on this weekend will be the next series where we are going to cover arthritis. So don't miss it, and this will create the continuity. So this Basildon A to Z course, we first of all, did it live in 2020 during the COVID. But the background is very old. So this started in 2007 actually, and we devised a course. We used to do twice a year. We used to do at that time. FRCR exam was twice a year, 2 attempts per year. So we used to do it for each attempt, and we devised a course in which we covered whole of radiology from the perspective of 2B exam. It was an absolute marathon course. Each edition used to take us 8 weekend days. And in 8 weekend days, from 9 till 9, 12 hours of teaching, absolute marathon. But the idea was to give A to Z type of a perspective from, a textbook, but in a 2B manner. So in 2020, the first exam of FRCR was cancelled in April, but the second one, it went on in October, and this was for UK candidates, and this is where gave us this idea to do this. And so this commenced on 25th of June 2020, 35 courses completed on 25th September. And overall, this course had 102 hours of teaching, 35 sessions. Average attendees per session were 538, so close to 19,000 attended it. In radiology terms, this is viral because I think in whole of COVID, we got a flyer from RCR that they did online teaching and 10,000 attended it. And this course was attended by close to 19,000. And actually that gave us the idea to start more formal teaching, and we started our ST1 2-year teaching program, etc. So this, Basildon A to Z course was quite special. We have not repeated it, and now I think this time we decided to do it for you people on weekends. So this is a bit of background. The problem in A to Z course is that it is like a textbook, in a textbook pattern. So you know where you are. So, on this slide, you can see that basically I devised it on, David Sutton, which is a textbook which I read when I was a student. The 1987, I joined radiology. Edition is the first book which I read. And the chapters are here, congenital infection, all of these things. And today I'm going to cover infection, avascular necrosis, and miscellaneous. So this is on the basis of David Sutton. On the weekend, you will see arthritis, and then tumor 1 and tumor 2, and then all of these. The trauma ones are covered in rapid reporting. The problem here is that though it's a beautiful pattern to cover A to Z, but in the exam it becomes more difficult. Today, when I ask you questions, it is infection. So you will say it is osteomyelitis, a lytic lesion, and this is osteomyelitis or a Brodie's abscess. But in the exam, it will be different. So beware of that. But having said that, you will find it very, very useful. Today, what we are going to do is we have got 6 candidates, but this is a message for the candidates. It's a time bar type of a thing. It's not classical potpourri viva. It's not organized like this. And there will be a bit of teaching, a bit of question. I don't know how many cases you will get in your 30 minutes. The first candidate is going to be with me for about 30 minutes, and it's your luck how many you get. So, and after 30 minutes, I'll go to the next and then next and next. This is what we are going to do. So, before we begin the first case, let's go through a bit of teaching about MRI of MSK. Now, if you see here, you will always get confused on marrow signal on T1 as an PD weighted sequence. So please remember that marrow signal fat appears bright signal on T1 as well as PD weighted sequence. For marrow abnormalities, the key sequence actually is T1 and a stir sequence, which is this one. T1 and stir is the best sequence. You know, anything where you want to check for marrow abnormality, even trauma or infection or tumor, etc. But PD non-fat saturated will also give you similar marrow signal. It all depends what kind of scan you are doing. It all depends on your clinical, what is it? If it's a knee MR and you are talking about, is there a meniscal tear? A PD fat saturated sequence is the key sequence which is used to pick up ligamental, meniscal, tendons, abnormalities. But if there is marrow abnormality, which is the clinical trauma, infection, tumor, then T1 and stir is the sequence. In the exam, please remember that it is very difficult for you to say that this is stir and this is PD fat saturated. And I'm not showing you, but I can also do a T2 fat saturated. T2 fat saturated is out of now fashion in UK particularly. So it's a good idea to have this term in your vocabulary, water sensitive sequence. Water sensitive sequence. Water sensitive sequence by definition are fat saturated sequence. So edema or anything which has got water content will be bright. You can have a stir sequence, which is most sensitive. Then you can have a PD fat saturated, and you can have a T2 fat saturated. So if you're not sure, in the exam, just use the word water sensitive sequence. So this is an MR of ankle, and it tells you various kinds of sequences. In your day-to-day practice, I think the most used sequence is a PD fat saturated sequence, where ligaments and tendons and anything menisci, etc., they are well seen. Candidate 1.
Yes.
We have got a MR of the distal and distal forearm. What do you think? Which sequence is this? Where I'm pointing out? Can you see my mouse, please?
I can see it now. Yes, sorry. This is, I think this is a T1 sequence. But sorry, there's fat saturation. Yeah, the fat is saturated. I'm going to go with proton density.
You see the proton density in T1, the fat, the marrow will be fatty. It will be bright. You got confused there. You were right, actually. Because you see, if you see these carpal bones, there is bright signal here, right? This is fatty signal. And here, what is happening, there is something abnormal.
Yeah.
So this is a T1 weighted sequence in which this portion of marrow, which is radius, is abnormal. Right? Once you see the abnormality on T1, which sequence you should compare it with, first of all?
Stir.
Stir. So this is a stir sequence. And of course, in the exam, you can also say fat, water sensitive sequence. So now considering this and this, what are your findings? Over to you.
So in the region of the diaphysis, distal diaphysis of the radius, there's an eccentric, well-defined low signal intensity on T1, high on stir. There is adjacent to it a similar looking lesion, but of smaller size. There's also surrounding edema.
Right.
There is no cortical breach or soft tissue component, and it is a narrow zone of transition with a sclerotic margin.
Right. So the word sclerosis, use it for plain film and use it for CT scans. Use the word low signal here for it is low signal on all sequences, that kind of a thing. Now, so till now, what do you think is your conclusion?
I feel this is a non-aggressive lesion, and my differentials will include potentially a non-ossifying fibroma or possibly a simple bone cyst.
So non-aggressive lesion. Okay, we'll come back to this. On this case, I just wanted to concentrate on sequences. What is this and what is this?
The last two are fluid-sensitive fat-saturated sequences.
So,
STIR.
This is a STIR? Can it be anything else?
Could be a proton density.
So, basically, this is a pre-contrast fat-saturated T1, and this is a post-contrast fat-saturated T1. So let me sum it up. When you see an aggressive lesion, a marrow lesion, I'll come back to what it is, but right now just concentrate on the sequences. The key sequences are T1, non-fat saturated, and a STIR sequence. When you want to give contrast, what you do is you do a T1 fat saturated sequence and then a T1 fat saturated post contrast. In this case, what is happening that on this T1 weighted sequence, there is a well-defined lesion here within the distal diaphysis, and which has got a high signal rim, a satellite lesion here, surrounding a lot of edema, and the edema is low on T1, bright on the STIR sequence. This lesion and this is satellite lesion, they are fluid signal. Now, on pre-contrast fat saturated sequence, this is how it is, high signal rim. And then post-contrast, it shows enhancement, rim enhancement. So considering this, what do you think it is? Give me the diagnosis.
Sorry, I was muted. I think given the edema, it does look like an inflammatory process. So either an abscess, I think an osteomyelitis is the most likely thing.
Right. So this is a Brody's abscess. This is a Brody's abscess. I'll show the same case in a while on a plain film, and then we will learn the radiology part of it. But right now, I'm just concentrating on the sequence itself. One thing which I want you to remember here is this is known as penumbra sign. What is penumbra sign? Penumbra sign is an exam sign. They will ask you in the exam also, where this is a sign for an infective process or a Brody's abscess. And the key point to remember is that on the infection appears on a non-contrast T1 weighted sequence, the edge or the peripheral margin is high signal on T1. This sign is known as penumbra sign. In the spine, taking same concept, the key sequences are for marrow, T1. On T1, if you see this is a T1, you will see high signal in the fatty signal in the vertebrae, and this is a STIR. STIR is a fat saturated sequence, and that is why it appears dark. T2 weighted sequence is not a good sequence for marrow abnormalities. It is a very good sequence to look, of course, at the cord or anything in the dural space, etc. Now, this is a pre-contrast fat saturated, and this is a post-contrast. In this particular case, you can see some enhancement here, and this was a case of metastasis, dural metastasis, as well as some parenchymal metastasis were there. But the key message here is what are the sequences which we will do in for marrow. Now, this is a, we know this fracture here. We know that there is a fracture. What do you think about rest of the marrow? Is it normal or abnormal? Candidate one.
The rest of the marrow looks normal, except for C. I'm looking at C6, which displays a high signal intensity.
Okay. So, yeah, so that high signal intensity, I'm not interested, but tell me about rest of the marrow, whole of the vertebra.
Sure.
Whole of the spine.
Mm-hmm. So other than this, I do also note in the upper thoracic, that would be T3. I also note a similar higher signal. In the lower thoracic and lumbar vertebra, I can see uniformly normal signals return from the vertebral bodies and intervertebral discs. There is slight loss of height and dehydration of the intervertebral discs at spaces T11, T12, and T12.
Just tell me about the marrow signal. Normal, abnormal, whole of the spine.
Normal.
Okay. So, if you see here, this is a normal spine, just to make a comparison. This is a T1 weighted sequence, and this is a stir sequence. If you see the fatty marrow, it is bright, and look at the adjacent intervertebral disc. The key formula is that normal marrow should be, normal intervertebral disc should be lower in signal, or should we say that the vertebra should be higher in signal as compared to the intervertebral disc. This is the key formula to remember. And similarly, in rest of the MSK, if there is an adjacent muscle, then look at the marrow on T1 and look at the adjacent muscle. And the key formula is that it should be, the marrow should be more or brighter in signal intensity as compared to the adjacent muscle. So in the spine, compare it with the intervertebral disc. In the rest of the MSK, compare it with the adjacent muscle. Then look at the stir sequence. Stir sequence, by definition, is short tau inversion recovery. That's the physics term. But look inside the marrow and you will appreciate that the marrow is suppressed. So there is nothing watery there. If there was anything watery, it would have been bright. Now look at the marrow in your case. Look at this vertebra and just ask yourself, this is the vertebra where my mouse is. Can you see my mouse? It's a laser one.
Yes, I can.
Okay, and then look at the adjacent intervertebral disc. Is the marrow signal lower than the intervertebral disc or brighter than the intervertebral disc?
It's lower than the intervertebral disc.
So what does that mean? Normal, abnormal? Lower is abnormal. It should have been brighter than the intervertebral disc, like this case. And then look at the stir sequence. And on the stir sequence, it is higher. It is, it is watery. You have to, this is what I say, develop your eyes. So you should know how a normal stir looks like. Normal stir will fat saturate. Now, if there is too much of water and which is looking bright. So key point to remember is low signal on T1, high on the stir sequence means marrow infiltration. It can be infection. It can be, this was a case of multiple myeloma. It can also be a case of diffuse metastasis because everything is abnormal. Whole of the spine is abnormal. And it can also be in other parts of MSK also, you will get similar findings. So this is another case of whole spine where you can see metastasis. And for example, just concentrate on this one. And this one is low on T1 and bright on the stir sequence. So key take home point is for marrow, T1 and stir are the best sequence. For if you want to do post contrast, then you will do a pre-contrast fat saturated followed by post-contrast. Okay, before we proceed further, I want to make an announcement, and this is for next week. Don't miss this session next week, which is the RCR concepts of real learning from your own mistakes. This is the part one, and then we will do a part two also. And please remember, the idea is that I will invite all of you then to use our platform to present something if you want to. So we will give you this concept of learning from your mistakes, the real concept of RCR next time. And I will ask all of you, if you want to do something on our platform in future, and we can take it further. But the details I will tell you next time. Now, the key thing is that for that next time, if you see here, there is a pre-session poll. It's a very simple 10-second poll. 3 questions are there. If you please use your the QR code, use your mobiles and fill up this right now. I'll give you time for this. It will give, it is a 10-second thing. And co-hosts, if you can please put the link also in the chat. Next week, we will take it further, and you will find it extremely, important concept, which we will tell you, and then in future, we will invite you to be part of this project. So I'm just waiting now, and I think the co-hosts have posted the link also, and I'll just give you 1-2 minutes more. And during the session also, you will have you will have a lot of opportunity to fill this up. Just 3 questions. This is very important for us if you can do it right now. Done. So I can see a few dones on the excellent. So I'll just wait for another 30 seconds and then we will proceed. Thank you, those of you who have done, and those of you who are doing it. So meantime, candidate 1, what is the best sequence for marrow? What are the best sequences?
T1 and stir.
T1 and stir. And what is the formula? T1 should be?
T1 marrow should be darker than disc, and stir marrow should be brighter than disc.
That is, you're talking about abnormal, right? Here.
Yes, yeah, sorry.
Okay, then.
Actually, good. Sorry, I think I'm a little bit confused now. Sorry.
So, let's remember it like this. What is normal marrow? Normal marrow is brighter than the intervertebral disc. Normal marrow on a T1 weighted sequence, and it is brighter than the muscle. Just remember it like this, and from there you can generate the abnormality, which will be lower. Are you with me now?
I am. Yes, I got you.
Yeah. Okay, let's continue. Okay, this message I've been giving you previously also. This is a Viva course organized by Dubai FRCR. So this is the email, face-to-face Vivas, very extensive feedback, very good course to learn from. You'll get 6 Vivas, 4 hours, 8 hours Vivas as observer. So if you want to register for this, this is 31st of August and 1st of September. This is in Dubai, Rashid Hospital, Dubai. And this is the email, dubaifrcr@gmail.com. Okay, now this is your first case.
I
Candidate one, this is your first Viva case, and because of time factor, this patient has got left-sided symptoms. So concentrate on left side. Over to you, please.
I'm presented with an anteroposterior frontal radiograph, abdominal radiograph of a pelvic radiograph of a 21-month-old child who is unwell. I can see ill-defined lucency in the proximal femoral neck of the left femur with surrounding periosteal changes and slight interruption of the medial cortical margin. And also I can see that the femoral epiphyses bilaterally have maintained height as well as these spaces. Now, reviewing the rest of the skeletal components, the medial aspect of both pubic tubercles, as well as the left inferior pubic ramus, do look more lucent when compared to the remaining bone. The sacroiliac joints appear to be preserved. I do not see an abnormality with the ilium bones bilaterally. To conclude, I believe the main abnormality is a lucency in the left proximal femur with cortical periosteal reaction of the medial margin. There's no soft tissue bony component.
So if you think where my mouse is, you think there is a periosteal reaction here?
A bit further distal.
Here.
There.
Okay, so don't worry because this is the lesser trochanter. It is whatever you are saying, disregard that. What is happening here? Try to describe this finding where I am just using my mouse around it.
It's around the femoral epiphysis. There appears to be.
It is metaphysis. This is the epiphysis. So this is the metaphysis. Yes, please.
In the region of the metaphysis, when compared to the other side, I do see a longitudinally shaped lucency, which extends to the margin, the proximal margin of the metaphysis. I do not see any fractures and no soft tissue component in that region.
Okay, just 1 second. Is there a soft tissue component here where I'm pointing out?
It's when I compare it to the other side, it doesn't look like there is.
Okay. So, considering this finding, and this is an unwell patient also has got symptoms, what is your conclusion?
So in conclusion, there is a linear lucency in the metaphysis of the left femur with soft tissue changes that may suggest an effusion. In an unwell child, I'd want to correlate with their symptoms clinically to see if they have fever or raised inflammatory markers. I would refer my findings to the clinicians and recommend an ultrasound of the joint to see if there's any fluid that may be causing any problems. So my suspicion is that this could be an infected joint in this unwell child.
Okay. So basically, what is happening in this is we'll come back to the case. this is infection, and there is involvement of the metaphysis. And this is what I say, that I see what the mind knows. In a child, I'll show you a few slides. In a child, metaphysis is where the infection occurs. And in an infant, it's slightly different. In an adult, adult and infant are similar. Always look at the metaphysis for infection. And so here we can see a lucency with subtle surrounding sclerosis. This is it. But uh, three fat planes should be in your vocabulary around the hip. And this they will ask you in the exam. What are these fat planes? These are three fat planes. One is known as this one, which is you remember that the iliopsoas is coming and it is being attached here at the lesser trochanter. So this is the iliopsoas fat plane. This one is known as capsular or gluteus fat plane. And this one is known as obturator fat plane. Obturator fat plane. Now, these should be in your vocabulary and you should understand how you will pick them up. For example, in this particular case, you can see that there is a lucency here. Look at this obturator fat plane. I know it might not be projecting very well, but the eye see what the mind knows. Compare this with this one. And this is the obturator fat plane, and you will see that it is displaced. So there is distension of the joint. And these fat planes are distended. And this is one of the findings which you see in infants or in children in osteomyelitis. You did very well where you said that I want to do an ultrasound because that is what they are going to ask you in the exam. Please remember, septic arthritis is a emergency is the word I'm using. It's a medical emergency. Do a ultrasound, take out a sample, confirm that this is infection, and they might take the patient to the theater for lavage, etc. Now, look at these words, distension of capsulator. So this is a case from a textbook. And here, compare this side versus this side. You can see normal fatty type of density here. Here, there is a bit of distension, a bit of soft tissue. Look at the difference. But just concentrate on the distension of the fat planes. Every case will not be like this, but of course, you should know. In the exam cases, look at this, how there is a bulge of the capsular fat plane. And obturator is not very well projected, but you can make out. Again, the lucency is here. Sometimes what happens is that the head of the femur, it can be displaced laterally. So the effusion is here. That is why the distance from this part to this part will increase as compared to the other. So all of these findings you have to look for and you have to describe them. A few terminologies which should be, the concept should be in your mind. Osteomyelitis is infection of the bone marrow. Acute osteomyelitis is symptomatic osteomyelitis, by definition, less than 6 weeks duration. Plain film is not good here. Chronic osteomyelitis, and here MR is very good. In chronic osteomyelitis, by definition, it will be more than 6 weeks. And there is another term which we call infective osteitis, infection of bone cortex. Usually, there will be juxtacortical infection. So these words and these concepts should be in your mind. These terms are all exam terms, and these terms, I'll show you cases where you will use them. But first of all, the definitions. Sequestrum. Sequestrum means separated. It is a fragment of dead bone surrounded by granulation tissue. It will be more sclerotic than the parent bone. Please remember. Then involucrum, meaning wrap in, to wrap in. And this is layer of living periosteal new bone formation around the dead bone. I'll show you cases to explain this. Cloaca, meaning drain. this is the opening in the cortex or involucrum. So you will find a hole. So you have to tell the examiner that there is a cloaca, cortex or involucrum, through which sequestra, fluid or granulation tissue is discharged. And then Brody's abscess. What is Brody's abscess? I showed you a Brody's abscess, by the way, on that MR. Focal area of chronic osteomyelitis with abscess and surrounding sclerosis. So this is hematogenous infection here. And then there is a subperiosteal abscess. Then there is a dead bone here, which is the sequestrum. And of course, when this dead bone passes through this, so this thing is the involucrum, which passes through it, we call it cloacae. So scans from pictures from Radiopedia. So you can see this lucency here. This is a chronic osteomyelitis. This sclerosis here is sequestrum. And if you see the cortex has got endosteal as well as periosteal thickening. There is a sequestrum here. Look at the marrow cavity and you can see that it is slightly obliterated. And this is that opening. There is a bit of cortical tunneling, which we will come back to shortly. Same findings on MR. Please remember that sequestrum will be low signal on all sequences because it's sclerotic. And look here, there is a breach here, and that from that breach, infection is going out. So this is the cloaca. One key point to remember is that pattern of hematogenous osteomyelitis of tubular bone. The key point to remember, you can take a screenshot of this one, is that in infants and adults, there are something common. What is common? That usually in infants, there is metaphyseal osteomyelitis, which extends to epiphysis. So joint involvement is common. Similarly, in adults, the infection is epiphyseal, and that's why joint involvement is common. And in child, it is, in the, let's say 2 years old onwards or 1 year old onwards child, it is less common. The concept behind it is anatomy, epiphyseal vessels and metaphyseal vessels, which pass through the growth plate, etc. Similarly, involucrum and sequestrum are more common in infant and childhood, but less common in adult. So look at this case of chronic osteomyelitis, which has presented with fracture, secondary fracture. So if you go here, pathological fracture. Infant and children, not common. In adult, it is more common. This is an example where we can see thickened, bone, sequestrum, and fracture here. Okay, from here, we come to an exam term, which is known as button sequestrum. This is very important for the exam. What is a button sequestrum? It is basically a small sequestrum surrounded by lucent rim, commonly seen in calvarium, but can be at other places. In the exam, they will show you this kind of a case. This is a classical 2B case where you will be shown a skull X-ray in which there is a lucency and there is central sclerosis. So this is a button sequestrum. And this is a CT scan of the same thing. And the differential diagnosis, what can it be? So, candidate 1, what is the differential diagnosis of button sequestrum?
So, lucent lesion in the skull, Langerhans cell histiocytosis,
Yeah.
eosinophilic granuloma. Infection, so well, not osteomyelitis, no. Probably metastasis from maybe a neuroblastoma, potentially.
Neuroblastoma will destroy things. It's very aggressive, right?
Mm-hmm.
So key point is this differential diagnosis, take a screenshot of this. Remember this. Button sequestrum. Nobody will say LCH as the first one. You will say that this is a chronic osteomyelitis. It can be including for TB, then LCH. And rarely, these two tumors, as in lymphoma, malignant fibrous histiocytoma, and you will see them in the long bones. They can have sequestrum. But the one in the skull is what I really want you to remember. This one, LCH and chronic osteomyelitis. And the concept in LCH is that the central portion, it becomes necrosed actually. And that is why you get button sequestrum. This is a case of lymphoma where you can see a very aggressive lesion here. And this aggressive lesion has got a wide zone of transition. There is, cortical thickening here. There is periosteal reaction. There is a lucency here. But the key point is that there is a bit of sequestrum here. So just to give you an example from StatDX of a sequestrum in a lymphoma. But I think the key thing which you have to remember is skull and these two, LCH and osteomyelitis. The differential diagnosis, always remember an osteoid osteoma. So this is a classical exam film. In the exam, what you will see is you will see cortical thickening. So there is cortical thickening here. And the differential diagnosis of this, of course, is also a stress fracture. And you will ask for a CT scan. On a CT scan, you can see this nidus. It is within the cortex. So this is a classical osteoid osteoma. Key point to remember is that X-rays are not very sensitive in acute osteomyelitis. MR is the investigation of choice. In chronic osteomyelitis, of course, you can see, but in the exam, they will show you plain films, by the way, just like the ones which I showed you. This is your last case, candidate 1, then we'll go to candidate 2. So what do you think is the finding on the left side?
Thank you. Frontal pelvic radiograph of a skeletally immature patient. There is a rounded lucent lesion within the proximal femoral neck, which is eccentric and close to the medial margin. There is evidence of surrounding sclerosis. There's no periosteal reaction or soft tissue bony component. On review of the remaining skeletal components, there's no abnormalities or similar lesions I could see in the femur, ilium, or the pubic bones. The femoral epiphyses heights are preserved and are not collapsed. So differentials for a lesion with a narrow zone of transition and a sclerotic margin. So to me, this looks like a non-aggressive lesion. I would inform the clinicians and gather if there's any systemic upset or fever, but non-sclerotic rim, narrow zone of transition, I would suspect this may be non-ossifying fibroma. Although I would normally expect it in the kind of tibial metaphysis region, but this is possible. There's endosteal scalloping of the cortical margins, so potentially a bone cyst, and other differentials, but not very likely is an aneurysmal bone cyst. But there is no kind of multiloculated appearance or septa within. So I would go with non-ossifying fibroma.
This patient has got pain.
And I would also consider, I would consider an infective cause for such a lesion. As
look at the capsular fat plane. Compare this with this. What do you think?
It appears displaced.
And this is the iliopsoas fat plane. What do you think?
It does represent possibly an element of effusion adjacent to that lesion. So I would also consider an osteomyelitis or potentially.
Okay. So now the point is, in the real world, what will happen? This is the case of, again, osteomyelitis. Similar to the first one, which I showed you, the anatomy, this was slightly It was a metaphyseal lesion. It is a lytic lesion with some sclerosis. Fat planes are there, but I think part of the hint is about what we call that the patient was symptomatic. Now, uh, other than this, you did consider differential diagnosis. You mentioned, so this is, the differential diagnosis that a lytic lesion in the metaphysis can be ABC. You did consider this. You did consider non-ossifying fibroma. But the key point was that this lesion, aneurysmal bone cyst, will not have this marginal sclerosis. Non-ossifying fibroma, of course, uh, the marginal sclerosis can be there, but it will be thinner. But the main point is that it is symptomatic, and then look at the soft tissue, the capsular and the iliopsoas fat planes, they are distended. So, this is another example of the eye see what the mind knows. So, what we have seen in these cases that in the exam, in a young age group, always look for these metaphyseal lesions and look for hip is a favorite, and for that you will ask ultrasound. What will you do? I'll do an ultrasound. It is an emergency. You will call them. They take it very seriously because within a day or two, the cartilage etc. will be destroyed. So the relevant differential diagnosis in this case, I think you were not off the mark because you did consider ABC and non-ossifying fibroma, but because of the factors which I just discussed, both of them can be disregarded. So look at this picture, and this is what happens. This is that hematogenous osteomyelitis. With that, there is effusion, and radiologically speaking, this is the bulge which you can see, and the capsular bulge which you can see, which I pointed out on the previous share. Brody's abscess per se can be at other locations. It is usually metaphyseal, but please remember it can extend to the epiphysis. So it can be subarticular also. And candidate one, thank you very much.
Thank you very much, Dr. Khan.
Okay, candidate two, are you with us?
Yes, sir.
Okay, so madam, this is penumbra sign. Just describe the findings. What is the penumbra sign? Where do you look at? Which
At T1, I would find a high signal intensity REM of a low intensity.
Which one of these are T1?
Sorry, the one at the far left of the screen or the right side. Yes,
yeah,
this
one
without fat SAT. And then the middle one is a STIR or a fluid sensitive sequence. I think both are fluid sensitive sequences. The coronal and the other two.
Excellent. So what is the penumbra sign? Describe it for the audience.
So it is a REM of high signal intensity on T1 weighted image of a low signal intensity lesion, which would have a fluid signal when compared with other sequences of the lesion. And it would be characteristic of a Brody's abscess.
Excellent. So main point to remember is that on a T1 weighted sequence, a Brody's abscess or intra-osseous abscess has got high signal REM on a T1 weighted sequence. This is the key point to remember, and you can call it a Brody's abscess. This one, again, is metaphyseal, but it is also extending to the epiphysis. So this patient is a prisoner. He ended up in the prison because he had a fight and on a Saturday night, fist fight, and then he developed some symptoms. Over to you. What are the findings here? What is your diagnosis?
Presented with a zoomed in radiograph of metacarpophalangeal joint, I assume. There is a subtle lucency with involving the metacarpal head. I'm not sure. I think it is the ulnar aspect at the left side of the image.
Yeah,
Okay.
fifth.
Okay, at the ulnar aspect of the image with surrounding subtle sclerosis. There is also narrowing of the joint space and sclerosis at the other side of the joint. So I'm concerned about infective process. So it might be osteomyelitis.
What is happening to the joint space?
There is narrowing of the joint space.
Okay, so
compared
this
to the other.
is, yeah, that's fine. So this is fifth metacarpophalangeal joint. You did well. Basically, point to remember is that this is what we call indirectly a human bite, fist fight. So, you know, the saliva of the other person is what will cause this. And, you know, the rate of infection is quite high in this kind of scenario. And basically what is happening is that if you see here, there is loss of definition of the head of the, look at this, and there is loss of definition. One can argue that there might be subtle erosion here. With that, there is loss of joint space. Key finding in osteomyelitis is loss of joint space. So in a PEDS group, initially the joint space can enlarge. Why? Because of effusion. But once there is cartilaginous damage, then it will reduce. And then there is a soft tissue component. So this is septic arthritis, metacarpophalangeal joint. So here we will skip this. The key point for the exam is this one: ultrasound. Highly sensitive. Ultrasound is the diagnostic method of choice for hip effusion, also guides aspiration, and they will ask this again and again. So we consider it a medical emergency. Remember that. MR is very sensitive, 100% sensitive, specific is 77. And the key point is that low signal on T1, flute sensitive, it will be high signal. On a post contrast, what will happen? There can be two things. One is inflammatory phlegmon. Inflammatory phlegmon will enhance. And if there is an abscess, then there will be surrounding. So abscess will be infected fluid, or it will be necrosed fluid with marginal enhancement. Yes, please. 37-year-old male, left-sided symptoms. Over to you.
Yeah, I'm presented with AP pelvis radiograph of a skeletally mature patient. There is narrowing of left hip joint with lucency of the acetabular roof, I think. And there is also subtle lucency of the involving the femoral head with admixed with sclerosis. There is also distension of the fatty planes, particularly the iliopsoas and the capsular. Also, I think the obturator is also distended. So my first differential diagnosis would be septic arthritis. I would do ultrasound to confirm my findings.
Adult. You can do ultrasound, but better is what?
So to do MRI?
Yeah. So in children, you know, the point is that ultrasound, confirm it and aggressively treat it. This is quite a full-blown case. Here, what is happening is, you know, distension of the, you know, the fat planes will be difficult in adults to see. But what is happening is that there is soft tissue, you know, obliteration of the fat plane, and there is increased density, which is, you know, here there is fatty, and here there is a bit of soft tissue. Key finding is that the joint space is reduced. And then look carefully. And key finding is the acetabulum. And look at this acetabulum. It is crisp and sharp. look at this articular surface. Here, that is gone. And you look carefully, and there is this bony destruction. There is a lytic lesion, actually, which is on the acetabular component. So this is, acute osteomyelitis, septic arthritis, should I say. And this, appeared ultimately proved to be TB, but nobody is asking you, or nobody can diagnose that this is TB. Just say that this is infection, septic arthritis. Next case. This patient is 80, female, dementia, fever, bed sores. Over to you.
I'm presented with a pelvis radiograph of an old age female patient. I can see that there is destruction of the femoral head with dislocation, and also there is air, multiple air locules projecting over the proximal end of the right femur. So I am concerned about septic arthritis caused by gas-forming organism, maybe.
And
Destruction.
what is happening to the surrounding bones?
So there is osteolysis of multiple bones, particularly the pubic rami bilaterally.
Right. So in this particular case, we can see that there is bony destruction. This ischium. There is, the acetabulum is completely destroyed if you compare it with this acetabulum. And where is the head of femur? That is gone, actually. It's all eaten up. And so even the neck is eaten up. The key finding is this lucency, which was well picked up by the candidate. This lucency means air. Where is this air? This air is within the joint space, and it is causing this destruction. So this has to be septic arthritis. Now, on this MRI scan, we can see this is a T1, this is a stir, this is post-contrast. And we can see the same findings. The air, of course, is low signal on this post-contrast as well as pre. On post-contrast, we can see this enhancing phlegmon. And here, of course, there is no fluid, there is air, which is surrounding high signal or enhancement. But the key finding in this case was that there was air here, and there should not have been any air here. Well done. Okay, this is the case for which I showed the MR to candidate 1 initially, and I'll again show you the MR, but can you describe your findings here?
Yes.
It's a classically very good 2B case.
So lateral and frontal radiograph of the left forearm and wrist joint of a skeletally immature patient. There is an ill-defined oval-shaped lucency seen at distal diaphysis of the left radius bone with surrounding sclerosis. There is also some surrounding soft tissue distension seen on the lateral view. So appearances are those of aggressive lesion. My differential diagnosis would include infection, maybe Langerhans cell histiocytosis, or even Ewing's sarcoma, considering patient's young age.
So why did you say aggressive?
Well, it has a wide zone of transition, and
right. Excellent. Okay. So the point is that when you see a case in the exam in the bones, this is a big term. Now, if you see here, of course, I think next session is tumors, where we will consider all of this in great detail. When you see a tumor, what are the 10 things which you look at? Age, location, zone of transition, margin of the lesion, tumor matrix, pattern of bony destruction, periosteal reaction, cortical response, soft tissue involvement, size of the monostotic or polyostotic. In this, other than age and location of the lesion, the key thing is zone of transition. always, 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 it should be in part of your description. This is just like in brain. If you see a tumor in the brain, is it intraaxial or extraaxial? And the differential diagnosis totally changes. So, zone of transition similarly is a key word which you must remind yourself that I am describing a lesion in the bone. I have to tell in my report and to tell the examiner what is the zone of transition. And that will really help you. Zone of transition, by definition, means transition from abnormal to normal bone. Narrow zone of transition means benign lesions. And this is an example of a narrow zone of transition where you can see crisp and sharp outline, normal bone, abnormal bone. But in our case, look at the zone of transition. There is something abnormal here, but all of this looks abnormal. All of this looks abnormal. So you're not very sure where is the normal and where it becomes abnormal. And the candidate did very well. Please remember that when you see a wide zone of transition, you do not use this word that this is malignancy. Use the word this is an aggressive lesion. And between the line, what are you telling the examiner? Aggressive lesion can be infection. Aggressive lesion can be a tumor. Again, the candidate did well because in this age group, what are the aggressive lesions which can cause this type of finding? Ewing's is the key top. And then, of course, LCH, you can definitely keep it in the differential. One thing I want to add is that there was a bit of periosteal reaction on the lateral. So this is the case which we did see initially when I was showing you MR of MSK. And here, this is a T1 weighted sequence. This is a stir sequence. This is a T1 fat saturated, T1 post contrast fat saturated. This is pre, this is post. So you can see that the penumbra sign. Actually, this is one abscess and there is a satellite abscess here also, Brody's abscess. A lot of edema, which is low on T1, high on the stir sequence. And it shows enhancement, intraosseous abscess. Now on an axial sequence, you can see that there is a sort of a cloaca, which is communicating with the surrounding soft tissue phlegmon, which is enhancing. You can see this enhancement, and look at this hole here, the breach in the cortex. Yes, please. Madam, are you with me? Maybe you are muted. Let me check.
I'm sorry. I
Yeah.
was muted.
Yeah.
I'm presented with left leg radiographs of a skeletally immature patient. There is ill-defined lucency seen at proximal shaft of left tibia with surrounding cortical thickening and sclerosis. There is also periosseal reaction seen on the AP radiograph, I think medially. And I can't see any soft tissue extension, but maybe there is some soft tissue edema, surrounding soft tissue edema. So again, appearances are those of an aggressive process, considering the wide zone of transition of the changes. And my differential diagnosis would include infection, Ewing's sarcoma, and maybe Langerhans cell histiocytosis. I don't think the lesion is intracortical, so I'm keeping osteoid osteoma out of the differential.
CT and MR for you.
Okay, on CT scan, I can see a central lucent lesion with surrounding bony sclerosis and a defect coursing cranially, so in keeping with cloaca. And there is on the MRI, I can see that there is ill-defined hypodense lesion with, okay, wait. So we have a T1. We have a hypodense lesion with a hypointense rim on T1 weighted image and corresponding hyperintense signal on fluid sensitive sequences. These are both steer on the axial. There is also a sinus tract communicating to the surrounding phlegmon. So appearances are those again of chronic osteomyelitis.
Okay, fine. Thank you. So actually, the problem is that this is not projecting very well for you on this PowerPoint. Otherwise, if you look carefully, just look what is happening. You can see there is some lucency here. And again, it is not projecting for you, but I want to highlight that you can see a linear lucency here. Linear lucency, actually, you can see here also. And this is what we call cortical tunneling. Tunneling is the word, tunnel. And tunnel is very specific for osteomyelitis. Now, it is chronic osteomyelitis. Now, look what happens. Look at, there is end osteal, new bone formation here. And that is why, look at the medullary cavity, it is all encroached. And similar findings here, where you can see this, this tunneling. It is breaching the cortex. It is going in the medullary cavity. And of course, the same finding on MR. And then you can see this cortical breach, and you did very well, where there is a sinus tract and perifocal abscess. So well done. Another case of osteomyelitis. But my main idea was to show you cortical tunneling, which is not visible to you because of the projection or the quality of the X-ray. Well done, candidate 2. Can we take candidate 3 now?
Thank you.
Yes, sir.
Candidate 3 is a co-host. Yes, are you with me, candidate 3?
Yes, sir. Yes, sir.
Okay. Describe this lesion in this rib. Over to you.
Provided lateral projection view of the frontal and lateral projection view of the right one side of the chest, showing a ill-defined lytic lesion involving the
Slightly,
anterior.
your volume is slightly. Can you please speak up?
Sure, sir. Am I audible now, sir?
Yeah, better.
Yeah. Ill-defined lytic lesion involving the anterior aspect of the rib. Sixth rib on the right side, on the right side, with a small area of sclerosis in the central aspect, wide zone of transition. I can see some surrounding soft tissue as well. So yeah, this is with wide zone of transition, some periosteal reaction. I would think of an aggressive bone lesion infection. And it's look like it is a 15-year-old child, so I would keep the differential less likely.
I'm waiting for the
Infection.
other differential you wanted to say.
Sir,
Other than infection, what is your
trauma, trauma, but unlikely this aggressive feature. And yeah, that's all I can. Langhans-Cell
Enchondroma. Okay, and what else?
Langhans-Cell histiocytosis.
Okay,
LCH.
what else? What else?
Ewing's, but it's unlikely.
And why do you say but for Ewing's?
Sir, first of all, it's a flat bone, usually seen in the long bones in the diaphyseal location. And the reason is the soft tissue component is less.
Okay, thank you. So, you see, this is a case in which what we see, first of all, the findings, and then the differential diagnosis. So there is a rib here in which there is destruction. Now, all of this rib is destroyed here, this lucency. There is periosteal reaction where I'm pointing out. So there is a very aggressive lesion. Now, once you pick that up, then the differential diagnosis is what we are talking about. Now, the differential diagnosis, just on a CT, you can again see there is bony destruction and some soft tissue component. Now, the differential diagnosis, focal rib lesion, solitary or multiple. Please remember that the examiner wants the differential diagnosis in this case, right? In this case. So you did confine yourself to a young age group, 15 in your differential, but enchondroma, this is not at all enchondroma. Enchondroma is not an aggressive appearance. It will not cause this destruction, etc. Ewings, by the way, Ewings in flat bones is more common. What I mean is that you apparently have got this concept that it is more common in long bones and not in flat bones. No, or axial skeleton. No, that is not true. Any bone, particularly in this age group, infection and Ewings, blindly you should talk about them together. And of course, on a plain film, you cannot commit how much is the soft tissue component. So aggressive lesions, infection and Ewings, they go together. Please also remember, even clinically, they go together because both of these lesions, infection and Ewings, Ewings can present with infection-like symptoms, actually. Raised ESR, fever, etc., etc. So in this particular case, the differential diagnosis is the key thing. And for that, the key thing in this age group is, so this is in a child, right? It was 15 years old. So the key thing is osteomyelitis. And other than that, LCH. And other than that, Ewing sarcoma. If you want to keep metastasis, okay, I'll accept that. But you cannot and cannot consider enchondroma in the differential diagnosis.
Yes.
Okay, candidate, this is candidate 3. So aggressive or non-aggressive lesion, what do you think?
Aggressive lesions.
Describe it for me, please.
Ill-defined lytic lesion involving the mid shaft of the fibula with a wide zone of transition and adjacent interrupted periosteal reaction in the lateral aspect and also in the medial aspect. I can see solid periosteal reaction as well. The solid periosteal reaction in the lateral aspect and some soft tissue extension into the medial interosseous portion. Other than that, I can see a small lytic area in the proximal shaft of the fibula as well. So it's possibly cortical
Proximal shaft of
tunneling.
what? Say again.
Proximal shaft of
Of fibula.
So it's ulna, sorry.
Right.
Yeah. Possibly cortical tunneling. Not sure. Yeah.
So the main point is that this is an aggressive lesion. It is not lytic. It is destructive. You don't see a lucency. I'm just debating that term, lytic lesion, you said.
Okay,
So
sir.
don't think that all aggressive lesions you will see a lucency there. Don't think that. That is why I'm elaborating on this. It is causing a lot of, if you look in detail, this cortex is destroyed. This cortex is destroyed. There is a periosteal reaction. And then other than that, soft tissue component, you did well. If there might be something. Now, the differential diagnosis is what we are talking about. Aggressive lesion here, mid shaft. So this can be, what will you consider?
Ewings and infection, osteomyelitis.
48 years old. Here comes the catch.
Okay.
Right?
Metastasis, yes.
So you see, in last case, you did very well, where you confined yourself to the age group of the patient. That was a 15-year-old, and you did well to give me a differential diagnosis, which was in that age group, But one thing we debated that enchondroma should not have been talked about. In this case, the differential diagnosis, you should not consider
Sorry,
Ewing's.
sir, I didn't notice the age. I'm sorry.
Yeah. So, okay, you did not read the age. Yeah. So this is so the key point which I'm making here is I have shown you so many times, and even today I projected that, but I did not talk about that in the examination, the the examiner wants you to tell them the differential in this case, which you are seeing, this age, this site, this radiological feature, this clinical features. What is the differential? So I take your point because today I'm showing you PowerPoints. Maybe you did not read the age. So that's fine. So in this particular case, Ewing should not be there. There are other tumors which can happen. This is a sweeping, differential from your book. There are other tumors which can happen here. And by the way, their osteosarcomas even happen. Diaphyseal osteosarcomas can
Yes.
happen.
Yes.
But so that is what this was. This case was. Okay. 48-year-old, of course, has got pain, swelling, fever. Over to you.
Provided lateral projection of knee joint in a 70 and lateral and frontal projection knee joint, 78-year-old female patient, present pain, swelling, and fever. I can see the post hip replacement processes. There is ill-defined lytic area involved, a permeative lytic lesion involving the proximal tibia.
Proximal tibia here.
Yes, sir.
So don't worry, this is all, a bit of osteopenia, etc. Don't worry about the tibia.
Okay. So other than that, I can see lytic areas involving the patella.
Sorry, say again. Which part?
Patella.
Patella. Okay, so this is also osteopenia. Don't worry about this. What else?
Then I can see an interrupted periosteal reaction involving the medial portion of the femur with the ill-defined lytic lesion in the distal femur. The corresponding to the anterior cortex
So
of the
you're
femur.
talking about this area where I'm pointing out?
Yes, sir. Yes, sir.
So this is also projectional. This is similar to this. This is quite a bit of osteopenia.
Okay. Other than that, I can see a obliteration of the soft tissue planes of the distal surrounding the distal femur with mm,
So this patient has got a total knee replacement, right?
replacement. Yes, sir. Yes.
So now the question is, with this kind of swelling,
Yeah.
what is happening? This kind of symptoms, I mean to say.
Possible and infective etiology, septic.
And on which radiological finding have you reached that conclusion?
The soft tissue obliteration of the
Soft tissue
distal
obliteration of
of the fat planes
which fat
in
planes
the
are we talking about? You're talking about suprapatellar fat plane and things like that. You see, fusion can cause this. Key finding in this case is this lucency.
okay.
You see this lucency. This is a classical
Yes.
exam film. This can come in your rapid reporting also, that kind of a case where uh, the between the prosthesis and the parent bone, you should not have this lucency. This means a bit of loosening. And with that loosening and with this, you pointed out there's a bit of effusion here. You call it that this is, infection. So that is the key finding, this lucency. Yes, please.
So provided frontal projection and lateral projection of a cervical spine, cervical spine of a 72-year-old male patient neck pain. Striking abnormality I can see is C5, C6 area. There is reduced intervertebral disc height and collapse of the partial collapse of the C5 vertebra and mild lateral with the widening of the prevertebral soft tissue at this C5, C6 location, and also extending up to the C4 to C7 levels. So possibly, yeah, spondylodiscitis with a prevertebral abscess. So I would inform this finding to the referring clinician, check with inflammatory markers, and also suggest further evaluation the MRI, contrast enhanced MRI cervical spine.
Excellent. Well done. So in this particular case, what is happening is that there is a collapse here. You can imagine that there was an intervertebral disc in between, which is gone, which is all eaten up. The end plate, vertebral end plate, inferior and superior, partly eaten up. There is a bit of localized kyphosis. And so when the disc space is gone, which is eaten up, it is taken as a sign of infection. Remember that. With that, I was looking for this finding to be pointed out, which the candidate did well. This soft tissue anterior to the spine has got various measurements, and in this, distal to C5, it is about 2 centimeter. But another formula to remember is that distal to C5, if it should not be more than the AP dimension of the vertebral body, there is a definite soft tissue abscess. So this case was TB, but I'm not expecting you to call it a TB. Just call it infection. That is fine. And the key finding is that the intervertebral disc is also destroyed. This is the differential in your book, multiple collapse vertebra. Of course, our case was a single collapse vertebra. Yes, please.
Yes. Provided frontal and lateral projection of wrist with proximal hand showing an ill-defined lytic lesion involving the distal radius, the epiphy distal radius with a wide zone of transition and a thin rim of sclerotic margin, and also there is associated cortical break in the lateral along the lateral cortex. No matrix mineralization, no soft tissue component. So it's aggressive bony lesion causing possible pathological fracture, and there is reduced joint space of the radiocarpal joints, and the radio-ulnar joint and the rest of the carpal bones shows normal, no similar lesions are noted. So there is an interrupted periosteal reaction, which is well appreciated on the lateral projection. So aggressive bone lesion with a 45-year-old female patient, I would think of again infection, one possibility. Other possibility will be a metastatic lesion. I would inform this finding to the referring clinician, discuss the case in the orthopedic and
Anything else in your differential?
sir. Giant cell tumor is not at this location. Usually it's subarticular, usually extend up to the lateral position.
You said it is not in this location. What does that mean? What do you mean?
It's usually extend up to the lateral subarticular location.
You mean to say it is eccentric?
Eccentric, yes, sir.
Your lesion is not an eccentric. If you see here, this is the lesion.
Yes.
Here it goes till the end. Here it is not going till the end. It is slightly eccentric.
Okay. Okay.
So can it be a giant cell tumor?
Yes, sir. But usually it's not that it's locally aggressive, but
right.
Not, yeah, it's locally aggressive, but not with
Anything
wide
else?
zone of transition.
Anything
With
else?
wide zone of transition, it's not possible.
Anything else in the differential?
Without any matrix, I can't think of anything else.
So there can be no other differential?
It can, sir.
Sorry, I asked you that any other differential, and you are saying that there might be something else also. What do you mean?
Multiple myeloma.
Multiple myeloma. 45. Good, well done, well done. You see, I was a bit harsh with you but that was intentional. And this is what I call grilling in the exam. And this is classical. The same thing will happen in the exam. 100% same thing will happen. And you did well, but you lost a bit of confidence. So you should have stayed firm. Let me tackle it. First of all, if you see, you described it very well. There is a lesion which, slightly wide zone of transition here, and then where were we? There is a bit of periosteal reaction. You did well. You commented that I feel that this joint space radiocarpal is also reduced. So perfect here. It was absolutely perfect. Then you said differential diagnosis, infection. And by the way, this is what it is. Of course, non-TB infection can also be kept in the differential. Nobody is expecting that you will call it a TB. Now comes the differential. In the differential, initially you were looking for aggressive lesions in the distal radius in a 45-year-old male. You said metastasis. Fine, I'll take it for the simple reason that it is rare, but it can happen. Absolutely, I'll take it. And then giant cell tumor. We started debating the giant cell tumor. So giant cell tumor, you were not convinced that this is giant cell tumor, and part of your reasons were right, but you lost your confidence. And that is the feedback from my side. You should not have lost the confidence. It is, and this is classical. Good that it has happened with you here, and good that people are listening, that anybody will tackle it like this. And in the exam, it can be very, sometimes it's a total benign lesion, and the final thing will be, can it be malignant? Yeah, the examiner will ask you, can it be malignant? And you have to stay firm. So otherwise, you did it very well. Well done.
Thanks.
Now, so multiple myeloma, by the way, you could not say in a 45-year-old, don't say that. Now, this is lucent epiphyseal bone lesion, and there are lesions which are related to the joint. Giant cell tumor is there, which is non-sclerotic margin, extends to the metaphysis, mainly in chondroblastoma is in young age group. Infection, of course, we have to keep that. Local specific lesions, this is Entellus calcaneum. Chondrosarcoma, no. And then comes these lesions, which can occur anywhere. For example, metastasis, you did well, where you mentioned that. Myeloma, we cannot keep in this age group. So it is a very, very good case for developing your concept of how will you deal with differential diagnosis in the exam. In this case, what is your differential? So, and to stay firm. And many times I use the word grilling, and you will be very disturbed. Oh, I have done so well, and the examiner is still grilling me. This is what they do at times. They keep going on and on and on, and try to check your confidence. So stay firm there. Otherwise, you did well. Well done.
Thank you so much.
Spot diagnosis, what is this?
So tuberculosis, tuberculous pontylodiscaris, bilateral calcified psoas abscess.
Excellent. So this is a case of chronic bilateral psoas abscess with calcifications, which can happen in historic TB. And if you see this gibbous deformity, the disc space is completely gone, and this is a old case of TB. Why I'm showing you is that what can happen is that they might show you, if an examiner has got this film and has something else going on, then you should have an idea that TB with calcification, old TB, can present like this on a plain film. So candidate 3, you have done very well. Well done. And let's take a 5-minute break. Today's session is 3 hours. It will go till 9:30. So take 5 minutes break, and I am stop sharing. My co-host, if you can project that poll once again, the pre-session poll once again. And for the 22nd session, can anybody project that? Project your slide, I mean to say. Co-host? Yes, and excellent. So we'll take a 5 minutes break, and please, those of you who have not uh, filled up this poll,
I can see there's altered area of marrow signal, which is appearing hypointense on T1, hyperintense on T2, and stir, which is involving the adjacent end plates, that is the inferior end plate of L5 and superior end plate of S1. And there's reduced joint space, and the joint space also appears irregular. And there's even the joints, intervertebral disc space also appears hyperintense on stir and T2. And on post contrast sequence, I could see that there is enhancement of the intervertebral disc space as well as the superior and the inferior adjoining vertebra. And there's some prevertebral collection as well. So in according to these findings, I'm thinking in terms of discitis. This could be a pyogenic discitis, and which could that is bacterial, which is involving the disc and the adjacent vertebra with the prevertebral collection, and there's no extension into the spinal canal. And as I'll inform these findings to the referring clinician.
Okay, well done, well done. So if you see here on a T2 weighted sequence, first of all, look at the intervertebral disc, and you can see a bit of fluid inside, which of course is not the, the nucleus pulposus, it's different. When you see a fluid on T2 weighted sequence, that is very worrying. Then look at the stir. On the stir, the fluid becomes more obvious, and then you see that there is edema in the adjacent both of these vertebral bodies. And if you see the end plates are, irregular. They are partly destroyed. And so if you just go for our formula of marrow signal, we can see that on T1 weighted sequence, the marrow is lower than the intervertebral disc. And of course, whatever is low is high on the stir. On post contrast, everything is enhancing. So please remember that when it is enhancing means there is no liquid component and it is still what we call a phlegmon. And bone marrow edema will also show you enhancement. The candidate did very well, where ruled out anything happening within the thecal sac. So this is, use the word spondylodiscitis, elaborating that there is disc as well as adjacent bone is involved. Well done.
Okay, sir.
Another case of spondylodiscitis. Uh, Here, what is happening is, let me describe the findings, then I will ask you a question. So if you see here, this is a T2, this is a stir, this is a T1, and this is a post-contrast T1. In this case, we have not done a fat-saturated pre and post, and that should have been done. But I just want you to ask a question to you. So on this T2, we can see that on this stir, we can see that there is high signal here, and look at the edema. Edema is high signal on stir. On T1, that is low signal. So till now, everything is quite obvious. Now this is pre and this is post. What is happening here? Over to you,
Sir,
Candy.
Sir, on the post-contrast T1 T1 sequence, I could see that there is a epidural collection which was appearing hyperintense on the which is enhancing. And so in this is a case of a spondylodiscitis with a epidural abscess formation.
Right. Will abscess enhance in toto?
That will show a peripheral enhancement. So in this case, it could be a phlegmon.
Exactly. So this is what it was about, this case, this finding. And this finding is extremely important finding. It is extremely important in head and neck also. By the way, it is extremely important in the liver also. But let me give you the context. But when there is an infection, there is liquefaction. When liquefaction happens, then there will be a liquid component, and the margin will enhance. That is drainable. Before that, it will not be liquid. So you put in a needle, there will be nothing to drain. In a liver abscess, this happens every day, and you might have seen cases where you are worried about infection, and you will tell the clinician, they will say, can you drain it for me? And you will say, we'll wait another 24 hours or 48 hours, and we will rescan, and when there is a liquid component, then we will drain it. So that concept holds very, very important concept in the spine, very important concept in head and neck also. Subperiosteal abscess of orbit, etc., etc. So you should have a clear-cut concept that just remember it like that infective, inflammation which is enhancing is phlegmon. When there is a liquid component, which is the abscess, then there will be ring enhancement, and the necrosed part will not enhance. So this is because they will ask you, what should we do? Should we go in? Should we drain it? Blah, blah. So you will tell them, no, it is not drainable. Okay, now, aunt mini case. What is a aunt mini case? Aunt mini case is where there is no differential diagnosis. In 2B exam, trend of aunt minis is less and less because the examiners know that candidates have mastered aunt minis. So aunt mini by definition is a case in which there is no differential diagnosis. But this is an aunt mini case. What is the diagnosis? Can you describe and give me the diagnosis? Still, you should know what it is. And I always say that in head and neck, for example, for a radiologist who does a lot of head and neck reporting, for you, a case will be aunt mini, but in the 2B world, still they will ask you because they know that your exposure to a head and neck case is not all that much. So over to you, candidate. What is this?
So I could see that the first metacarpal appears, especially the diaphysis portion, it appears expanded and is replaced by a expensile lytic lesion, which has narrow zone of transition. And there's no associated periosteal reaction, no cortical break, but there's associated soft tissue swelling. And I'm thinking this is a case of an infection. This could be TB dactylitis. I could see some a lace-like pattern within. My second differential would be in chondroma.
Mm. So, lucency, did you see a lucency in this case? This is basically, you are absolutely right. This is what we call uh, spina ventosa or TB dactylitis. Spina ventosa or TB dactylitis. Historically speaking, the word spina ventosa is a German word, means a short bone which is inflated with air, inflated with air. Interestingly, historically speaking, this is the first diagnosis, abnormal diagnosis, which was made on an X-ray, by the way, in a child. X-ray of a child was spina ventosa. Now, so basically, what is happening? This is a particular type of TB uh, in which there is expansion of the medullary cavity. Remember this word, expansion of the medullary cavity. It is a balloon. It becomes inflated like a balloon. It can be phalanx. It can be, the metacarpal or the metatarsals in also. And second thing is that there is expansion. So this is another example. This is another example of this spina ventosa. By the way, syphilis dactylitis is a differential, though I did say that this is an aunt mini because of the expansion of the medullary cavity. Enchondroma will be a lucent lytic. This is not a lucent lytic lesion. And that will be a lytic lesion, and that's different. Second thing is that in syphilitic dactylitis, there can be thickening of the phalanx or the metacarpal, but that is because of cortical thickening, periosteal reaction. So expansion of the medullary cavity, just remember that. So that is it. By the way, you did use the word lace-like. So let me show you a case here. Over to you.
So I've been provided with X-ray foot, AP and oblique view. I could see there's involvement of the distal phalanx of the first toe and the proximal phalanx of the second toe, which appears abnormal. There's appearance of abnormal lace-like pattern involving these phalanges. The adjoining joint spaces appears normal, and rest of the bones also appear normal. So, and there's no associated soft tissue swelling or no periosteal reaction, no cortical destruction. So this lace-like pattern is seen in sarcoidosis. So my first differential will be sarcoidosis.
Anything else?
Um, Second, I'll keep as TB dactylite. No, so sarcoidosis.
Anything else?
No,
TB
sir.
ruled out.
And uh, so there's soft tissue swelling of the first toe, and there's a bony erosion. So less likely gout, but this is not the position, so no other differential.
Okay, very good. Well done. But so first of all, let's go back to your original case. This is not lace-like. You use the word lace-like. This is lace-like. So basically, in sarcoidosis, what happens is there are punched out lesions giving you this lace-like pattern. It can be hands, it can be feet, small bones. Now you did very well as far as differential diagnosis, but how can so I was again grilling you, the word which I use, grilling you. Anything else? Anything else? And so there are two or three ways to deal with this kind of scenario. You actually dealt with it, but you could have been more emphatic. So uh, deal with it, uh, just like you did, where you said that I can consider gout. However, because of this factor and that factor, I can rule that out. Overall, this is pathognomic. This word should be in your vocabulary, pathognomic or classical. This word can be in your vocabulary. Now, that this is so the thought process, you are giving your thought process to the examiner. You are showing your thought process and then staying firm. So you did very, very well, but just a bit of a minor point. Regarding soft tissue swelling, can there be soft tissue swelling in gout?
Yes, sir.
Correction, in sarcoidosis. Correction.
Um, sir, don't know, sir.
Don't. Okay. Okay. So, lytic lesions in the phalanges and well-defined, and these well-defined include sarcoidosis and all of these things. Fine. Now, if you see, this is the answer to your question, to my question. Look at this soft tissue here. Look at this soft tissue. This is another case, and this is, of course, from StatDX. Inflammatory disorder of unknown cause resulting in non-caseating granulomatous deposits in tissues, including bone. So soft tissue swelling is very, very common. It can happen. Soft tissue nodule. Just remember that. So don't get confused if you find it. Now, just to highlight, I'm not going to go through it. Sarcoidosis is one of the favorites in the exam. And you for long cases, things like that, I have shown you cases in previous sessions regarding neurosarcoid, and I have told you that it is the greatest mimicker. So you can get long cases of anything from here and here, or from here to here. So you have to have a clear-cut idea. The second part of Chapman, there are things which are multi-system, and you should have a clear-cut idea. Remember my words, one line there will save the day for you in the exam. If you know that this is what there is. It is very well written by Hamid, the editor, and one line in this list will simply save the day for you in your exam. So always, revise it from there. It's very consolidated. Everything what requires for the exam, what is required is given there. Sarcoidosis, TB, you name it, everything is there. So virtually pathognomic in the setting of clinical sarcoidosis, lacy lytic bone lesion. Virtually pathognomic. So this word should be in your vocabulary when you want to be very emphatic. Sir, this is pathognomic for sarcoidosis, or it is classical for sarcoidosis. Stay firm there. And so clinical associated with pulmonary lesions in 90% of cases. So they might show you some X-ray and a plain film as a long case. So small bone sarcoidosis is associated with skin lesions. So remember that soft tissue component can be there. Another case of sarcoidosis, and this one is multiple lesions in the bones in the hands. Yes, please.
So I've been provided with X-ray lower limbs of a skeletally immature child. I can see there's a eccentric lytic lesion which is involving the medial metaphyseal corner of the bilateral tibia, upper tibia, and there's apart from that, I could see a smooth periosteal reaction, which is bilateral symmetrical, which could be physiological in this case, this age. And however, I cannot appreciate there's no joint swelling. So in my differential would be Blount disease, and second, there are no Wimberger ring sign and any other findings, so it is not scurvy. And um, so third, I'll keep as infection.
Which infection?
So could be a septic arthritis because of these lytic lesion. However, I cannot see any appreciable joint effusion, and so this scurvy, uh, because of this epiphysis has that Wimberger ring sign. I'll keep my differentials of scurvy as well, and these periosteal reaction might represent subperiosteal hematoma, and this medial pointing of the distal femoral metaphysis. This could represent Pelkin spur, and there's relative lucency just at the metaphysis, which could represent the Traumerfeld zone. So yes, these findings are representing features of scurvy.
So what is Wimberger's sign?
So Wimberger ring sign is when the epiphysis, it shows a sclerotic rim around, um, which is known as a Wimberger ring sign.
Okay, so I'll take over. You know, this is my favorite differential diagnosis in Chapman, and I do teach it in great detail. I can teach you 3 hours on this differential diagnosis, and it is a very important differential diagnosis. And as a monologue, I'm going to go into a teaching mode. I will like to cover it within, let's say, 5 to 10 minutes. It's a long subject. And in your, if you see FRCR exam, FRCR is a jigsaw puzzle of so many things. And one of those is differential diagnosis. And second one is your theoretical knowledge of things. So you should have theoretical knowledge. You apply your theoretical knowledge, and in the other side of the brain, you know, the right hemisphere has got a differential diagnosis, and in the left hemisphere of the brain is the theoretical knowledge. And as you are speaking, because the differential diagnosis is you are trying to evaluate or tell the examiner what it is. And many a times you can get a single conclusion. Remember my word, single. And it will be absolutely pathognomic. There is nothing else. And if the examiner grills you, you can again, hold your fort and just stay firm and tell your thought process and still do not change your differential. Now, first of all, let's go through a bit of the differential diagnosis and a bit of theory behind it. So look at these words. Normal infants, juvenile what is the differential? Periosteal reaction, bilateral symmetrical in children. Normal infants, juvenile idiopathic arthritis, acute leukemia, rickets, scabies, scurvy, prostaglandins E, and congenital syphilis. Now, please remember, one of the key factors is age. Age. So age of the patient is the key thing. And in this particular case, candidate, what was the age of the patient?
So I forgot.
This is the patient. What is the age of the patient?
So it's less than 6 months. I couldn't see the femoral head.
Excellent. Now, out of, if you just consider age, JIA, does it happen in this age group? Question.
No, sir. No, sir.
Acute leukemia,
No, sir.
rickets,
No, sir.
CAFEs.
Caffey's disease can happen, sir, but it
Okay,
won't be
less
bilateral.
than 5 minutes, huh? And 5 months. Scurvy,
No, sir. More than 6 months.
more than 6 months. PGI therapy. And what is this? Congenital?
Syphilis.
Can it happen?
Yes, sir.
Okay. Normal infants, can it happen? Physiological.
Yes, sir.
But you see, one thing you have to consider is age. Second thing is the radiological features. So let's go back. Now, you did initially tell me that it is normal physiological periosteal reaction. Now, this normal physiological periosteal, diaphyseal, no signal, growth plate, bilateral smear, single laminar, frequent femur, tibia, humerus, very unusual, more than 4 months, mimic trauma. Uh, this is what is written there. We'll come back to this. There is another differential diagnosis, which is radiolucent band, which can be metaphyseal band, and congenital infection is one of them. This case is a case of congenital syphilis, and it's a pathognomic finding. Pathognomic is the word. It's classical. There can be no differential diagnosis. And I can, why can there be no differential diagnosis? Now, if you see here, there is bilateral erosions of the upper tibial metaphysis. Bilateral erosions are pathognomic for congenital syphilis. Interestingly, this sign is also known as Wimberger sign. And by the way, in scurvy, there is a sign, the pencil thin cortex of the epiphysis, that is also known as Wimberger sign. But in scurvy, you will not see this erosion. With that, there is a lot of periosteal reaction. This is very exuberant. You will not see a single lamina. And usually in classically, in physiological, it doesn't happen like this. And you can see erosion here. If you stretch your imagination, maybe a bit of lucency in the metaphysis. And you remember there is a differential diagnosis here, solitary radiolucent metaphyseal band, and congenital infections is one of them. Now, you did very well regarding the age of the patient. Now, age of the patient is judged by the head of the epiphysis of the head of the femora. So the head of the femora in girls, it can appear anywhere between 3 to 6 months. In males, 4 to 7 months. And we don't see that. You are absolutely right. So the age is definitely less than 7 months. Scurvy, by the way, can happen in after 6 months, because till 6 months, the ascorbic acid goes from the maternal blood to the fetus or the baby, should I say. You see this, people think that congenital syphilis you will not see in UK. No, you will see it in UK. This is 2017, by the way, quite old, but it says 5920 cases of bacterial infection, up 12% from 2010. And this is from your book. Syphilis is divided into tertiary syphilis and congenital syphilis. So I'm not reading from here, but I just want to highlight this, that congenital syphilis, this is same page, a bit of a blow up. Early onset 0 to 2 years. Which bones are most commonly involved? Tibia, femur, humerus. Periosteal reaction, common find bilateral symmetrical. Metaphysis, lucent band and irregularity, focal destruction of medial. Look at this. Focal destruction of medial proximal tibial metaphysis, bilateral, is pathognomic of Wimberger sign. Pathognomic. End of story. This is what I tell you. In Chapman, you will find a sentence there which will save the day for you in the exam. Each and every sentence is very important. So there can be other findings like saber shin, etc. This is the Wimberger sign we are talking about. This is from StatDX. Destructive lesion in the medial tibial metaphysis, through which, same thing which we have already covered. This is the erosion. A portion of metaphysis is still intact here, and this is known as Wimberger sign. And please remember that Wimberger sign, the same sign, is also seen in scurvy. We will come back to this. So this is what I say: develop your eyes, train your mind, and your theoretical knowledge and your differential diagnosis. So in the exam, what does a differential, what we call I use the word a distinction candidate. What does a distinction candidate do? The differential diagnosis is in the mind, and they go through it and rule out pertinent negatives and positives according to the age and according to the radiological findings. So quickly, let's see this. This is the finding in NAI, where you can see this single lamina along the ulna, and classically, uh, of course, there can be other bones also, but in this example, there is ulna. It is not like the periosteal reaction, which was in your case. This is a case of JIA, juvenile idiopathic arthritis. We will not even consider it in our differential diagnosis. This is 2 to 4 years, and the periosteal reaction is along the phalanges. So this is, we'll not keep it in the differential. Now, leukemia can cause moth-eaten bones, and it can cause periosteal reaction. It can be bilateral symmetrical. This is not the age group for leukemia, and the findings were also slightly different. It was not moth-eaten bone. Rickets is interesting. Rickets is anywhere between 3 to 18 months. It can happen. Lower limb first and wrist then. In rickets, it's a pseudo finding. What happens is, if you go back to your normal wear and tear of bone, under the periosteum, new bone formation happens normally. This is normal bone metabolism. So what happens in rickets, that this new bone, which we call osteoid, it is deficient of calcium and it appears loosened. So the periosteum is high density and the new bone formation is low density, and it can give you a pseudo periosteal reaction. It is a pseudo finding. And please remember, you will not see it in each and every case of rickets. But if you see this case, you can see a bit of bowing, you can see a bit of cupping of the distal metaphysis. So what you have learned from this case, that when you are considering the differential, your description, you have to rule out, tell the examiner during your description that there is no metaphyseal cupping, no bowing, or there is bowing, etc., pertinent negatives. So this is rickets, again from second part of your Chapman. I'm going to skip it. And then comes this disease, which we will cover once again in the last part of today's session, Kefi's disease. So what is Kefi's disease? Kefi's disease is idiopathic for unknown reasons. The age of onset is anywhere between 9 weeks to 5 months. So usually it is less than 5 months. It can actually happen. It has been reported at birth also. And some people have diagnosed it intrauterine on ultrasound, by the way. But in Kefi's disease, what happens is that for idiopathic reasons, or we don't know the reason, there is periosteal reaction. And with that, there is skin thickening, etc. The child becomes very cranky, and means it must be very painful condition. And it is a self-limiting condition. And usually after a year or so, it becomes fine. There is a type which is more chronic, and it might continue for a few years. Where is the periosteal reaction? Key point is that the periosteal reaction is mandible. If you see here, there is a periosteal reaction along the mandible. Then clavicle. Look at this clavicle and this clavicle, and you can see periosteal reaction there. And then look at the long bones. Periosteal reaction along the diaphysis. So diaphyseal periphoaxial reaction, thick periosteal reaction, can go to the metaphysis, but not usually to the epiphysis. If you see here, this ulna is involved, this ulna is also involved. So, and this clavicle is involved, this clavicle is involved. And then mandible. And in the exam, you have to ask the examiner, they will show you this long bone, and then you will say that I want to see the mandible. Mandible is very pathognomic sign of this. So remember, Kefi's disease, definitely you can consider in your differential diagnosis. Now, this is scurvy. Now, let's go to the next. This is from your Chapman, and this tells you Wimberger sign. You see, another Wimberger sign. That was syphilis, and this one is what? Wimberger sign, reduced epiphyseal density with a pencil-thin cortex. So, in the patella, you will see it in the patella. Because there is osteopenia, the cortex is high density, and this is known as Wimberger sign. In many cases of scurvy, I don't have time to teach you everything about scurvy, but because that we will cover in another chapter, metabolic, etc. But the key point is that in scurvy, what can happen? What can happen? It doesn't happen in each and every case of scurvy. What can happen is periosteal reaction. Why does it happen? Because of subperiosteal hemorrhage. Yeah, you remember that even lack of ascorbic acid, the mucosa starts bleeding, and the patients might come to you, I get a lot of bleeding in the mouth. So ascorbic acid might be less. So when that happens, and this is the type of case we are looking at in the exam, where first of all, please remember that scurvy cannot happen before 6 months of age, because the the ascorbic acid from the maternal blood goes into the fetus. So first 6 months are fine. Then it can occur. So periosteal reaction will occur along the and this will be subperiosteal bone reaction, and it can happen within days, like this. And if you see here, this is the Wimberger sign, and there are other signs of scurvy also. So these can be your pertinent negatives when you are dealing a case in your exam. So this was scurvy. And then comes prostaglandin E1 therapy. So what happens is that these patients, they present with cyanotic congenital heart disease, and they want that the patent ductus, the ductus arteriosus should remain patent. And so that they buy time. At time, these patients are preterm, and they maintain it for a while so that they can do surgeries at a slightly advanced age. Now, because of multiple reasons, there can be periosteal reaction in these cases, and there is extensive periosteal reaction. If you see this case from Radiopedia, bilateral symmetrical from tibia, fibula, femur, radius, ulna, humerus. Humerus is less, but these are quite significant. Remember, there is nothing in the mandible. So this is prostaglandin 1 therapy. And then comes NAI. NAI is not mentioned in your in the Chapman, but it should be added. In corner fractures in the metaphysis can happen in case of NAI. Please remember that now we use a new term, suspected physical abuse, for NAI. So this is the new word which we use, new term, should I say. So the NAI term has been replaced by suspected physical abuse. And another one is vitamin A toxicity, which can occur in more than 6 months. And this is along the shaft here, tibia, and along the radius here. So this is the case which I showed you. In this case, if we go back into details, we can see that there is erosions at the metaphysis, medial metaphysis of both tibia, bilateral. And there might be some lucency in the, that metaphyseal band type of finding. Further erosions at the metaphysis, medial metaphysis of femora bilaterally, and incompletely visualized metaphyseal band. With that, there is quite exuberant periosteal reaction bilaterally. And you will start the case like this, that this is a infant which appears to be less than 7 months of age. I don't see any femoral capital epiphysis. And and then you describe these findings. Also, just, whatever the differential which is relevant in this age group, mention that other these erosions, rest of the bones appear normal in density. Then there is no evidence of Wimberger signs as far as the epiphyses are concerned. There is no Pelkan spur. There is no metaphyseal cupping. So indirectly, you're telling the examiner that I did consider in my differential these things, but I have ruled that out. In the end, you will say that the findings are pathognomic for congenital syphilis. End of story. And if the examiner grills you, you will stay firm. So this is congenital syphilis and nothing else. Okay, this was candidate number, sorry, I'm lost
4.
this 4. Okay. So, madam, now you know how to deal with this?
Yes, sir.
Okay, well done. Okay, Aunt Minnie case. What is this?
The leprosy, this look, there's licked candy appearance of the all the toes, and there's bony destruction of there's reduced density of all the bones and
Reduced
reduced
density. Are you sure there is reduced density?
no, sir, there's increased density. There are patchy areas of sclerosis, and there's a bony destruction, and there's leg candy appearance of the of second to fifth toes, and with soft tissue swelling, and so
Okay,
this is
thank you. Thank you. Well done. So this is a case of leprosy. And in leprosy comes under the, stigmata of uh, Charcot arthropathy. So this is a neuropathic joint. Please remember that Charcot joints or neuropathic joints, one of the pathognomic finding is that there will not be any osteopenia. They will actually have increased bone density. Now, in leprosy, what happens is that the cortexes, particularly of these metatarsals, they appear thin and sclerotic and elongated, uh, as if as if giving you the appearance of a licked candy. This is known as licked candy sign. So a differential diagnosis of arthritis with preservation of bone density and neuropathic arthropathy, which will be covered in detail on the weekend. Don't miss that. That is one of the differential. Just for your interest, this is from BMJ 1915. And here the paper is written that this is Indian Army soldier. So this is in India, Indian Hospital, Brighton, and this was Jamadar something, Jamadar MS, 1915. So this is the finding, and you can well imagine that it must have been a big finding because the patient has got soft tissues still intact. When they did an X-ray, this is the diagram which showed sort of, this pointed sclerotic phalanges. So sort of licked candy appearance. And we saw a similar case here in our hospital, it was a known case of leprosy. But just to make a point that you can still see, because these patients are still there in the population. And so this is what we saw in this 2011 case in our hospital. This we did not diagnose. It was a known case and it was all treated case of leprosy. Another one which we saw in 2015, by the way, and you can see this licked candy appearance. You see this licked candy. So look at the bone density quite increased. Another thing which can be asked in the exam is this calcification, and I just wanted to show you this from StatDX, that this calcification is digital nerves. Digital nerves. So if you see soft tissue calcification, They will say nerves, and this is an example which can happen. Okay, candidate 4. Candidate 4, we are through with the what we call this chapter, infection chapter, right? So the next chapter is a cakewalk. It is, spot diagnosis, which is good. This is your last case, and then I'll go to candidate 5. So give me your diagnosis.
So this is an X-ray pelvis frontal AP view. I can see that on the left side, the left femoral epiphysis appears, head epiphysis appears smaller in size, sclerosed, fragmented, and the underlying metaphysis also appears expanded. And on the left side, the hip joint space appears mildly widened. So this is a case of avascular necrosis of femur head, that is in a child. It is Perthes disease of the left side, and
What is
I'll
this
inform.
lucency? What is this lucency?
It's a crescent sign,
Okay.
subcon
Okay,
subcondylar fracture
well
sign.
done,
Yes.
well done. So, Perthes disease ranges between 2 and 14, but 5 and 6 is the most common. Please remember 10 to 15% are bilateral, and there can be early signs and there can be late signs. And this was subchondral lucency, which is the crescent sign, which the candidate did very well. In late signs, of course, it can be fragmented head. And when it is bilateral, the differential diagnosis is very important for your exam. I'll project the differential shortly. This is a slightly more chronic case where you can see this, fragmented sclerotic epiphysis. This is the type of case which is very important for the exam. I'll come back to this, but this is another one, unilateral. Now, if you see here, there is bilateral, sort of symmetrical, uh, fragmented epiphysis. Candidate 4, what is your differential? One differential, of course, can be bilateral Perthes. What else is your differential?
So this could be neglected slipped femoral epiphysis, and so infection,
Which
chronic,
infection? Which infection?
so septic arthritis, and
Examiner is not satisfied, madam.
um,
Anything else?
so bilateral osteomyelitis, or it could be
Okay, I'll take over. This is another very important differential diagnosis for the exam. Very, very important. And irregular or stippled epiphysis. So avascular necrosis, bilateral, we have already covered. 10 to 15% can be bilateral. This is what I want you to remember: congenital hypothyroidism. And I think 1 or 2 sessions down the road, we will cover endocrine on a weekend, in a recording, I mean to say. But this is extremely, so you have to know, you have to know these top 4 or 5. Morquise is an exam case because it can come with central tongues and things like that. Otherwise, this for me is very important: congenital hypothyroidism. So this is an MR where you can see that the normal marrow is lost and there is a bit of a mushrooming, expansion, etc. Thank you, candidate 4. Well done. Candidate 5, are you with us? Let me check. Candidate 5 is a co-host. I have made you a co-host now. Candidate 5.
Yes, sir.
Okay.
Yes, sir.
So, spot diagnosis, rapid reporting, normal, abnormal.
Uh, Abnormal, sir.
And what is the abnormality?
So the tibial tuberosity looks a bit avulsed.
Can that be a normal variant?
Yes, that can be a normal variant also.
You want to change your opinion, or you want to persist with your opinion?
Because I cannot see any obvious soft tissue swelling around it.
So if you see here where my laser pointer is, do you
Yes.
see this?
Yeah,
I don't know
but
if
I
it
can
is projected.
see that the tuberosity is looking avulsed. So I believe that this is a case of Osgood-Schlatter.
Yeah, you don't use the word avulsed. Avulsed is, post-traumatic. Just say fragmented. Fragmented.
Oh,
Fragmented tibial tuberosity can be a normal variant, but with that, when you see soft tissue swelling or thickening, then you call it. Of course, in your day-to-day practice, clinically the patient will have a pain here. So this is Osgood-Schlatter. Well done. Now, what is Osgood-Schlatter disease? Traction epiphysitis of patellar ligament insertion or tibial tubercle. Traction epiphysitis. So, uh, irregular fragmented and adjacent soft tissue swelling. So please remember, fragmented uh, is a normal variant or can be a normal variant. When you see adjacent soft tissue swelling, call it. And on MR, there will be bone marrow edema at this site. This is another case where you can see the similar finding where fragmented tibial tuberosity and there is a bit of soft tissue swelling. And this is an MR where you can see on this stir sequence, there is a bit of edema at the insertion site and maybe a bit of high signal within the patellar tendon. Another disease here, which is known as Sinding-Larson's disease. Here, if you see, there is fragmentation of the inferior pole, and on MR, this is a different case, by the way, this is a different case. We can see that this is the patellar tendon, and this is the origin at the patella, where there is a lot of edema. So what is this? This is traction tendinitis at the inferior pole of the patella. And on X-ray or a CT, there can be calcification or ossification of proximal inferior patellar tendon. Actually, this thing is the patellar tendon, which is ossified, which gives you this appearance. And when I started my radiology, if you read old textbooks, the first book which I read was 1987 Sutton. They had mentioned this at avascular necrosis. Can you imagine? So the concept at that time was that there is avascular necrosis of the inferior pole of the patella because MRs, etc., were not available. And later on, people understood that actually it is just traction tendinitis of inferior pole of the patella. And within that tendon, there can be ossification, which gives you this appearance, where gives you this fragmented appearance, etc. Sinding-Larsen disease. Normal, abnormal, your rapid reporting over. Candidate 5, are you with us?
yes, sir.
Normal, abnormal.
Just looking at um, the second metatarsal head looks a bit flattened to me,
Right.
and really sclerotic as well. It could be Freiberg's.
So the candidate has pointed this out, and this is Freiberg disease. Sorry, this was our case where we can see it's a classical rapid reporting case. And by the way, rapid reporting cases can also come in the Viva. Remember that. So this is it. What are the findings? Subchondral insufficiency fracture secondary to osteonecrosis of metatarsal head. This is what happens. Second metatarsal head 68%, third metatarsal head 27%. And there can be mortal sclerosis. There can be concavity of metatarsal head. Look here. Look at this. So develop your eyes on this finding. And if you get this in the exam, you should understand that this is also Freiberg disease, where there is a concavity here, as if there is an erosion here. This one, all of this is sclerotic and flattened. But this one, this concavity, develop your eyes on this one. Of course, on MR, there can be bone marrow edema. And so this was the case which I showed you, and this is a more advanced case, which is quite obvious that this is Freiberg's disease. Normal, abnormal.
So abnormal, then the navicular bone looks small in size and looks a bit sclerotic as well. So probably it's osteochondritis of the lunate. Oh, sorry, navicular.
Navicular. So this is Kohler's disease, avascular necrosis, and please remember it happens in childhood, but it can also happen in adult. And ultimately, in chronic conditions, chronic avascular necrosis, it can be very flattened and small in size, like this. Look at this one, how it is. Kohler's disease, referring to childhood onset osteonecrosis, right? But Muller-Weiss syndrome is the adult counterpart of navicular bone osteosclerosis. So it can happen even if you don't remember the names. Nobody's asking you the names, but please remember the concept that Kohler, by definition, was childhood, but it can happen in adulthood. 4 to 6 years, wafer-like thin, fragmented, patchy sclerosis, soft tissue swelling can be there. Yes, candidate 5. Can you describe this for me?
So there is a focal kyphotic deformity in the dorsal spine, along with the slight irregularity of the end plates of few of the vertebral bodies. So besides this, I'm also suspecting small Schomburg's nodes at few of the vertebral levels. So I believe that this is a case of Schurman's disease.
Excellent, well done. So, what is Schurman's disease, also known as adolescent kyphosis? So the concept behind it is that this is the proposed mechanism is that there is avascular necrosis of ring epiphysis of vertebra. So there is a ring epiphysis at the end plane. And this is also known as juvenile kyphosis, also known as adolescent kyphosis. And so when there is avascular necrosis of this, then the intervertebral disc, it goes into the end plates. It herniates into the end plate. Chamorro's node, by definition, is what we call intravertebral disc herniation. So this word should also be in your vocabulary. Intravertebral disc herniation is the same thing as Chamorro's node. And so if you read the nomenclature of disc according to the many societies, this is mentioned there, intravertebral disc herniation. So because of softening of bone. Now, what happens is adolescent means the name tells you it always happen in adolescent age group. And there will be multiple Chamorro's node, and anteriorly the vertebrae will be more compressed as compared to the posterior side, overall giving a kyphosis. By the way, it's a self-healing process, and gradually the patient becomes normal. So usually it is self-limiting. At times braces etc. are used to give support, but the prognosis usually is quite good, with greatest narrowing anteriorly. If you see here, so the greatest narrowing is anteriorly. This was our case, and you can see that the narrowing is more marked, and the anterior portion of the vertebra is also reduced anteriorly. Surgical treatment is only for more than 75% of kyphosis. Uh, Initial treatment including observation and bracing. Observation is no treatment, by the way. So, MR, same, or this is a 14-year-old with Scheuermann's disease, and you can see the same finding on this MR. So MR is also an exam place, remember. And if you see the end plates, or look at the end plates, and look at these intravertebral disc herniation, and look at the anterior portion, the height is reduced as if there is a compression fracture. So this is Scheuermann's disease. And more than three vertebral bodies, by definition, you see, this is from your book, multiple collapsed vertebrae, Scheuermann's disease. Children and young adult wedging of more than three adjacent vertebrae in lower thoracic spine with irregular end plates, displaced narrowing, and kyphosis. Yes, please.
So in this case, the diagnosis is already written. So
What happens here?
so in this, there is erosion seen at the medial tibial upper end of the tibia, and the epiphysis projects over it. So that
Erosion.
appearance.
What is the pathophysiology of Blount's disease? What is the pathophysiology of, let's say,
It is basically osteonecrosis.
is it
The upper end.
osteoporosis? Okay, in Madelung deformity, what happens?
So in Madelung's deformity, the inner third of the distal radial epiphysis is deficient.
Right. So something like that happens here also.
Okay,
What is the connection between Madelung deformity and Blount's disease for your 2B exam? Hint, both of these can be seen in a condition together. No?
No, sir.
Turner's.
Okay.
So basically, you see, this is the medial epiphysis of the tibia, and that is, deformed or whatever, and it gives you this kind of appearance. This case is more marked. This one is less marked. The only way it can come in the exam is, as a stigmata of Turner syndrome. Turner syndrome is important for the exam, particularly vis-a-vis two differential diagnoses. I think we have already covered it in congenital. These metacarpal, particularly the fourth metacarpal, can be smaller in size. And that's a very important differential, metacarpal, small metacarpal. Second thing is Madelung deformity. Now, if you see here, look, the mechanism is that the medial portion, you were absolutely right in your concept that the medial portion of the epiphysis of radius, it is not formed. And because of that, there is subluxation of the carpal bones and there is subluxation at the distal radio-ulnar joint. It's a bilateral finding in this case. In Turner's, Blount's disease can also happen. Otherwise, there is no importance of Blount's disease, but I just wanted to show you because of Turner's. This thing we have already covered previously. And this is the differential diagnosis for Madelung, and Turner syndrome is one of them. Spot diagnosis, what is happening here?
So scaphoid waist fracture with avascular necrosis of the proximal pole.
Excellent. So we have got a waist fracture here, and with that, there is sclerosis here, means that there is avascular necrosis of the scaphoid. And on this is a different case in which we can see avascular necrosis of the proximal pole, low in signal here and slightly high in signal here of the scaphoid. If you just concentrate on this X-ray for your rapid reporting, normal or abnormal. Just consider this one, nothing else.
This is abnormal.
And what is happening?
I think lunate avian.
Excellent. Lunate avian. And by the way, in your exam, this can come as a lateral. Please remember that three bones are in one line on a lateral wrist X-ray. One is radius, then is lunate, and the capitate sits in this cup, which is the cup of the lunate. And you can see that the lunate is compressed, it is sclerotic. So this is known as skin box disease. Osteonecrosis of the lunate, sclerosis and flattening. And this is another example, and another example, and another example. Okay, from here we come to bone infarct. Now, this is interesting. Avascular necrosis versus bone infarct. And this is very interesting that we have, just complicated the matter for ourselves. We use the word avascular necrosis when epiphysis is involved or the end of the bone is involved, subarticular portion of the bone is involved. We use the word avascular necrosis. And when it is any other, part of the bone, we use the word bone infarct. I don't know why, but this is what we do. And by convention, the term bone infarction is used when lesion is not in subchondral location. So when it is subchondral, you call it avascular necrosis. Otherwise, we call it bone infarct. Having said that, if you say something which is subchondral as a bone infarct, absolutely no issues because it is a bone infarct. So, and this example tells you that this portion here is not subchondral. So, and this one is subchondral. So, key point is that bone infarct is the same thing as avascular necrosis. Now, this is a Viva question. So, you have to have a clear-cut idea about this. And this calcification is a Viva scenario. Calcification on a plain film and double line sign on an MR T2 weighted sequence. So, bone infarct will show calcification, and this calcification is so dense that it is denser than the bone, so it projects, and this is usually serpiginous, calcification, and sometimes it can be amorphous sclerotic calcification. You have to differentiate it with calcification of an enchondroma, which is a cartilaginous tumor. A cartilaginous tumor like an enchondroma will have ring and arc or punctate calcification. I'll show you a few radiographs. And this scenario is important for your exam. Double line sign, what is a double line sign? And this is an exam sign. They will ask you in the exam. First of all, remember that this is on a T2 weighted sequence. It is seen on a T2 weighted sequence. There is an outer rim of low signal, usually serpiginous, which is the demarcation between living and necrotic bone. And then there is an inner margin of bright line. What is that bright line? That bright line is granulation tissue or inflammatory response. And internal to that will be either fat, or if fat is not present, it is all necrotic, then it will be lost. Double line sign, by definition, is a sign seen on T2 weighted sequence. Outer, and this is what they will ask, what is this? How do you explain this? The outer line is the demarcation between living and necrotic bone. Inner is granulation tissue, which is bright on T2 weighted sequence. You should know the etiology of bone infarcts, things like sickle cell disease, steroids, things like Casson's disease. All of these are very important, and there is a huge list. Now, this is can you, candidate 5, can you describe this
Yes.
for me? Here
So
on
in this case, there is bilateral avian, as evidenced by mild collapse of bilateral femoral heads, and along with that, I can see geographic areas in affecting the bilateral femoral heads and the subchondral location with crescent sign on both sides.
Right. So here you can see that double line sign which I was mentioning. For example, this line where I am pointing out, this is low signal and the inner one is high signal. Here you are. Outer is low signal and the inner one is high signal. And this is what the double line sign is about. And this double line sign is always seen on a T2 weighted sequence. Normal, abnormal.
I think. So can you change the window a little bit? I can make.
No. You can see the finding on this window. I'm on a PowerPoint. I cannot change the window.
Okay.
This is not a DICOM. But you can see the finding.
So maybe something at the medial. Medial femoral condyle is looking.
Medial femoral condyle. What is the abnormality? So you are right, but what is the abnormality? What will you put in the exam?
Maybe some osteochondral.
Excellent. If you look carefully, now this is the outline of the cortex. This is the lateral femoral condyle. Here, just trace this. And then there is a line which is normal, but anteriorly, you see this. There is a defect there. Something is missing there. So this is an osteochondral lesion. And osteochondral lesion, which actually you can see here where I am pointing out on a lateral. This osteochondral lesion, what will you highlight to the clinicians about this osteochondral lesion?
So I believe that this is unstable because there is a lucency surrounding it. So probably it's a.
Excellent. Well done. So this is a ring sign, which is a sign of an unstable osteochondral lesion. Give me spot diagnosis. What's happening?
So bone infarct affecting bilateral femurs and tibia.
Yeah. So if you see here, these are bone infarcts which are happening bilaterally, and this is the type of plain X-ray which you have to develop your eyes on. If you look carefully, look at the calcification. This calcification is that serpiginous type of calcification, which of course correlates with the findings on the MR. And on the other hand, look at this calcification. This is a enchondroma. Bone tumors will be covered separately. Enchondroma is a unique tumor where you find cartilaginous matrix in a long bone. In a short bone, as in hand, etc., you will see a lytic lesion. But in a long bone, usually you will not see a lytic lesion. On the other hand, you will see chondroid matrix. And the chondroid matrix is made up of calcification on a plain film. And it will be high signal on any fluid sensitive sequence on MR. But coming back to the plain film, chondroid matrix will be calcified. And look at this calcification of chondroid matrix will be ring, arc, punctate, ring or arc or dots, that kind of a thing. Incomplete rings, arcs, complete rings, arcs, or punctate type of calcification. This is a case of malignant transformation of an enchondroma. This is an exam case. We will cover it separately, but why I am showing you, they can show you a malignant transformation of a bone infarct. Please remember, bone infarcts can malignantly degenerate. And on the other hand, enchondromas can malignantly degenerate. And in this particular case, this is punctate calcification. This becomes a story. This case is a story. It tells you a story. The story is that originally this lesion was an enchondroma, and then it develops an lucency. If you see the cortex, this cortex is eroded, and there is a criteria which I will cover again when we do bone tumors, where more than one fourth or one third the thickness of the cortex is eroded, or the height of the lesion, etc. So it is causing, and you will say that this is malignant transformation of enchondroma. Key point to remember is that this is an enchondroma because of the pattern of calcification, which is ring and arc, which is like this. So, and on the other hand, classical serpiginous calcification uh, can be in bone infarcts, which can also malignantly degenerate. Okay, candidate 5. What is happening? What is happening?
I think humeral head avian.
Right. And what is happening here? The projection is not very good, so let me give you this thing. Same patient.
Bone infarcts in the knee as well, and I mean in the distal femur.
So bone infarcts at the head of the humerus, as well as multiple bone infarcts here. What can be the etiology? What can be the causes? So the viva can be on the causes.
So for bone infarcts at multiple sites, it can be because of drugs. NSAIDs, steroids intake, or it can be because of sickle cell, or it can be because of Gauchers also. So there's a lot of differentials which can be there and which needs to be clinically assessed to reach to a certain diagnosis.
Right. This one was actually Casson's disease. This is a Casson's disease, and that should be in your differential. This patient was a deep sea diver actually, so in Casson's disease, this is also known as bends. Basically, what happens is that when you go into depths, more than 3 atmospheres, which is more than, let's say, 99 feet, at every 33 feet, the pressure increases by 1 atmosphere, which is 760 mmHg. So at 66, it becomes, at 33, it will become 1 atmosphere, then 2 atmosphere. Correction, at surface level, it is 1 atmosphere. At 33, it will be 2 atmosphere. At 66, it will be 3 atmosphere. At 99, keep adding. This chap, I was talking to him, he had been diving till 180 feet, by the way. And the problem is not diving at 100 feet, 180 feet. The problem is that when you go into this kind of depth, then nitrogen, it gets dissolved in bone marrow. And if you lose your height, that is the main problem. Quickly, you cannot. If you decompress quickly, then what happens is that nitrogen is released from the bone marrow. It goes into the vessels, and it will cause, emboli, should I say, and which causes these pests. So Casson's disease should be part of your differential. This is your last case, and then we will go to candidate 6.
Okay.
What is your diagnosis here? Okay, go through your findings, should I say.
In this 3 months old child, x-rays which have been provided to me, I think there is some periosteal reaction which I can see in the right distal humerus, and in the ribs, in the clavicles again I can see that there is some periosteal reaction. So considering the a periosteal reaction affecting various parts of the body, I can see some periosteal reaction in the I think or radius as well, lower down. So I believe that this could be a case of considering the age of the child being 3 months. I was thinking on the lines of infantile cortical hyperostosis, but the age is little less for Caffey's.
Why do you say it is less? Why do you say it is less? What is the age of infantile cortical hyperostosis?
I believe it happens more after 3 months, or like that.
No.
Okay.
So
Okay, it will
yeah.
happen in utero also. Okay. So I believe
So
it's
what is the feedback? You see, the feedback is that your theoretical knowledge, how important it is. You picked up finding beautifully, but you were not able to diagnose it for the simple reason that you did not remember the age of Kefi's disease. Kefi's disease,
yes.
actually, I went through it when there was a case there earlier in the day. Anywhere between 9 weeks to 5 months. 9 weeks means 2 months to, but I also told you that people have actually diagnosed it. Some people think that it can be at birth, and some people have claimed it to see it on ultrasound, by the way, mandible, thick mandible, things like that, in intrauterine. So, having said that, once you pick that up, uh, clavicle, and then look at the mandible, must look at the now stretch of imagination that there is some soft tissue, and you will ask the examiner that I want to see an oblique of the mandible. There is nothing else, if you ask me, which can be in differential diagnosis in this. This is what we did this exercise earlier in the day. Now, if you look at the pattern of periosteal reaction, look at this board. This is diaphyseal mainly, and this is diaphyseal mainly. And that also I told you. So there is nothing else in this thing which should be in the differential. It's a pathognomic finding in this particular case. Kefi's disease, uh, mandible clavicle show diffuse periosteal scapula. So the key thing is we have already covered it. So I told you it can be self-limiting, etc., etc. Uh, age of 9 weeks to 4 months. Here you are in utero diagnosis. So people have also diagnosed it in utero. And so this is classical diaphyseal, and this is mandible in. So these are from stat dx from other examples. This is, I think, the same example with mandible, 1 month. This is 1 month old. You see, 1 month old. Kefi's disease. This is from stat dx. And this one again diaphyseal. Candidate 5, thank you very much. Well done. You've done very well.
Yes, sir.
Candidate 6, are you with us? Let me check candidate 6. You are now a co-host.
Good evening.
Okay, good evening. Good evening. Well, so you are still around. That's very good. So this is Kefi's disease, in which serial radiographs shows you how it has become normal, a bit of modeling deformity. Otherwise, it has become normal in serial radiograph. Another example where we can see that there is periosteal reaction, clavicle, stretch of imagination, something is happening here. You will tell the examiner, I want to see the mandible. If the examiner has got the mandible, will show you. Look at this case. Now, these are the teeth. Actually, this where I'm pointing out is the mandible. And this thing, everything is new bone formation. So very, very thick mandible. So you have to ask for it to the examiner. Okay, over to you.
Yes, I have been presented with a frontal skull radiograph for an 71-year-old male patient. The first observation, I noticed that there is diffuse thickening of the skull vault of this patient. I cannot see any thickening within the mandible. Also, I can see the orbital cavity appear within normal. In my routine practice, I want also to check the lateral view for this patient if available. Yeah, in this lateral skull radiograph, I can see that there is a well-demarcated area of lucency seen in the frontal aspect of this skull. I can see that there is two metallic-like structure.
Yeah, don't worry about it. That was a bandage applied.
Okay.
What is your diagnosis?
My diagnosis, it could be those changes of metabolic lesion. I will put on my differential diagnosis Paget disease, which can cause thickening of the skull and can also cause the lucency lesion in the frontal aspect.
Excellent. Well done. Well done. So this is Paget's disease, and in Paget's disease, what can happen is that there can be, there are three phases actually. One is the lytic phase, which is very active phase. One is the mixed phase, and one is the sclerotic phase, which is very chronic. Key point is that it will cause thickening of the calvarium, and so this calvarium thickening is there, and there is a lucency there. We call it osteoporosis circumscripta, and this is classical Paget's disease. Paget's disease should be discriminated with fibrous dysplasia. And in fibrous dysplasia, usually calvarium is not as much involved as the base of skull, as well as the facial skeleton. But I'm not covering fibrous dysplasia right now. We will cover it more elaborately in head and neck. So this is a case of Paget's disease. Another case which can come in the exam, and when you do a bone window, only then, so the examiner can show you some finding, and Paget's disease as an incidental finding. And when you say that I want to do on a brain CT, I want to check, or in my usual practice, I check it on a bone window, you might find this. I just wanted to show you a gross case of Paget's disease, whole of the calvarium is involved. Over to you, candidate 6. Your case, please.
Yes, I have been presented with frontal and lateral radiograph for the leg. I can see that there is lucency seen involving the proximal metadiaphyseal of the right tibial bone, and there is a sharp transformation into the normal bone distally, giving the appearance of blade grass sign. Also, there is no cortical destruction, there is no cortical bone matrix, and there is no periosteal reaction. My differential diagnosis, this is a classic appearance of blade grass sign and representing Paget disease.
Excellent, well done. Now, the lytic phase of Paget's disease, at times, those candidates who haven't seen it, they find it difficult to diagnose, and this is the example. Paget's disease, by definition, is a disease in the long bone which goes to the subarticular portion of the bone. So remember that, subarticular. One exception is tibia. In tibia, it might go just to the tibial tuberosity. At times, it can extend to the subchondral portion, but it goes till the tibial tuberosity. So otherwise, in long bones or tubular bones, you will see it go till the end of the bone or subchondral portion or the epiphysis, whatever you want to call it. Now, in this particular case, if you see here, there is a lucency. And this lucency extends anteriorly in the cortex, blade glass appearance, flame shape appearance, and it is lucent. So the eye knows, I see what the mind knows. And with that, you can imagine that the anterior cortex is thickened also. But the main thing was, don't get confused of this lucency. Paget's disease is as is, and in this example, you can see the coarse trabecular pattern and a bit of increase in thickness, coarse trabecular pattern. Within that, if you see a lucency, don't get confused. The cases which are good for your 2B prep also.